Well, thank you so much for joining us today as we discuss the central role of the rheumatologist in the management of systemic autoimmune rheumatic disease associated interstitial lung disease, current guidance for screening, monitoring, and treatment. I'm Dr. Bryant England from the University of Nebraska Medical Center.
Hi there, and I'm Flavia Castellino from Mass General Hospital.
Here's a brief overview of today's program's outline. We're going to start this off talking about a brief overview of systemic autoimmune rheumatic disease associated interstitial lung disease. We'll take you through a few different interactive case-based sessions, one on RA-associated interstitial lung disease and another on systemic sclerosis-associated interstitial lung disease. We'll then discuss some new treatment guidelines and emerging therapies, and then finally summarize and bring this all into one piece. Now let's start with an overview of systemic autoimmune rheumatic disease-associated interstitial lung disease. Now, interstitial lung disease is a chronic, inflammatory, and fibrotic lung disease. This is a common manifestation that occurs in patients with systemic autoimmune rheumatic diseases. Some of the key words in this are that this is a chronic disease. Unlike other types of lung disease, viral or bacterial pneumonia, once interstitial lung disease is present, it does not typically resolve. This is something that will be with the patient the rest of their life. We frequently see interstitial lung disease on a CT scan. So shown at the bottom of this slide are a couple different CT scans from patients with systemic autoimmune rheumatic disease, interstitial lung disease, in two different patterns. Now, when we look more broadly, interstitial lung disease can happen for other reasons as well, with the most common reason being idiopathic pulmonary fibrosis, where there's not an accompanying rheumatic disease. But if you look at every single person who has an interstitial lung disease, about 20% of those cases are related to a rheumatic disease. That's really showing the critical role a rheumatologist plays in helping identify and take care of these patients. Now that we know that interstitial lung disease is common in our rheumatic diseases, what rheumatic diseases do we really worry about this complication developing? And the way I like to approach this is with two different buckets. A bucket of very high risk rheumatic diseases and another bucket of high risk rheumatic diseases. So those in the very high risk group. Now, in these conditions, 40 to 50+% of people with rheumatic disease will have interstitial lung disease. So the conditions in this very high risk group include systemic sclerosis, idiopathic inflammatory myositis, and mixed connective tissue disease. The conditions that we think about in the high risk group, where the prevalence is 10 or greater percent of patients are afflicted with interstitial lung disease, include rheumatoid arthritis and Sjogren's disease. This study is a systematic review and meta-analysis evaluating the prevalence of interstitial lung disease across systemic autoimmune rheumatic diseases. So in this table, what you see in the far left is the different rheumatic diseases. In the middle, you see the pooled estimate for the prevalence of interstitial lung disease in these conditions. And then we've color-coded on the far right, again, with the same color for very high risk in red and high risk in orange. There are very high risk conditions, systemic sclerosis, myositis, mixed connective tissue disease. You can see in this meta-analysis, the prevalence of interstitial lung disease ranges from 41 to 56%. For our high-risk conditions, rheumatoid arthritis and Sjogren's, the pooled estimate for the prevalence was between 11 and 17%. Now, importantly, in this study, they were evaluating clinically apparent interstitial lung disease, meaning patients were having symptoms that led to this being detected. We know from other epidemiologic studies that if we evaluate people for interstitial lung disease who don't have symptoms, we will find additional cases. Thus, these are likely an underestimate if we consider very mild or subclinical cases of interstitial lung disease. One of the challenging features of interstitial lung disease is that it's a heterogeneous disease. One of the ways that we try and understand the variability of the disease is by categorizing it according to the interstitial lung disease pattern. So on this slide, we're taking the three most common patterns that we see in rheumatic disease: usual interstitial pneumonia, nonspecific interstitial pneumonia, and organizing pneumonia, and we're going to contrast a CT scan and typical lung pathology slides. On the far right of this slide, what you'll see is a normal chest CT scan and normal lung pathology for reference. Now, starting on the far left, the UIP pattern. This is the pattern that is also observed in idiopathic pulmonary fibrosis. In this CT scan, what we see is we see some reticulation change happening in the subpleural regions, meaning the area just below the pleura. In the base of this picture, we can also see some early changes of honeycombing occurring. Now, if we take a lung biopsy and examine that, what we'll see is we'll see these fibroblastic foci, where these are myofibroblasts that are being deposited. We can also see increased collagen deposition. One notable thing that we don't typically see much of in these situations are lymphocytes and inflammatory cells. Now, if we contrast that with nonspecific interstitial pneumonia, in this CT scan, what we are seeing is we're seeing ground glass change that is occurring. We do not see honeycombing in this CT scan. In the lung biopsy and NSIP, we're seeing more inflammatory change. We're seeing lymphocytes that are being deposited within the interstitium. In organizing pneumonia, what we see is a more consolidative appearance. So in this CT scan, we can see this consolidation occurring. This is the same type of feature you might see in a typical pneumonia. The difference being that this is in multiple different areas of the lung. And on a lung biopsy here, what we would see is we might see fibroblastic plugging of the alveoli and dense inflammatory cells in that same region of the alveolar septum. Now, there are other patterns of interstitial lung disease that are also present in rheumatic diseases, such as lymphocytic interstitial pneumonia, which classically goes along with Sjogren's syndrome, as well as diffuse alveolar damage and desquamative interstitial pneumonia. Now, these different interstitial lung disease patterns that occur also tend to group based on the underlying rheumatic disease. So this study is again that systematic review and meta-analysis, and they evaluated the different patterns of interstitial lung disease and how those relate to the specific rheumatic disease. I'm going to point out the three most common patterns that we just looked at in the prior slide: UIP in dark blue, NSIP in this turquoise color, and organizing pneumonia in this lighter green. In rheumatoid arthritis, which is at the top of this figure, we see that the most common pattern is UIP, which approximately 50% of cases of RA interstitial lung disease, with NSIP being the next most common. Now that's unique because for the rest of these rheumatic diseases, what we're going to see is that NSIP is actually the most common interstitial lung disease pattern present. That's the case for systemic sclerosis, myositis, Sjogren's, and mixed connective tissue disease, where overall about 50 to 70% of interstitial lung disease cases are related to NSIP. Organizing pneumonia is less common. Most frequently, we see this with our myositis patients and occasionally sometimes in rheumatoid arthritis or Sjogren's. When we see a patient who has rheumatic disease and interstitial lung disease, they don't typically come to us with a chest CT scan or a lung biopsy finding. Instead, as a clinician, what we are going to need to be aware of are the signs and symptoms of interstitial lung disease. The most common symptoms that our patient is going to present with will be a dry, non-productive cough and shortness of breath. Other symptoms patients may have include chest discomfort or fatigue. But very importantly, these symptoms may be mild, or as we hinted at earlier, may not even be present as interstitial lung disease is starting to progress. The other challenging factor is that some of these same symptoms are present in many of our patients with rheumatic diseases. For example, fatigue is a very common symptom that patients experience related to many different rheumatic diseases. Thus, it can be challenging for a clinician to identify whether their underlying rheumatic disease or interstitial lung disease may be driving these symptoms. It's important for us to investigate and identify interstitial lung disease because it has significant impact on patients' outcomes. We know that interstitial lung disease, when it's present in a patient who has a rheumatic disease, it reduces their survival. Shown on this slide are two different studies, one in rheumatoid arthritis and one in systemic sclerosis, where they evaluated survival after a diagnosis of interstitial lung disease. You can see in both cases that the patients who have rheumatic disease-associated interstitial lung disease had much poorer survival compared with the patients who did not. In rheumatoid arthritis, on the left, we see that patients with RA-ILD had a median survival in this study of less than 3 years. On the right, when we compared survival in systemic sclerosis to systemic sclerosis-associated interstitial lung disease, we found that the presence of interstitial lung disease reduced their lifespan by 2.5 years compared with not having interstitial lung disease. Thus, interstitial lung disease is significantly limiting our patient's lifespan. What impacts patients' lifespan with interstitial lung disease is not just having it present, but it's also how severe the disease is. Again, if we look at two different studies, one in rheumatoid arthritis and one in systemic sclerosis, and we define the extent or the severity of their interstitial lung disease, what we find is drastically different outcomes. So in both of these studies, what they did is they defined extensive interstitial lung disease based on having chest CT findings with more than 20% of the lung involved, and also having a forced vital capacity from their pulmonary function testing that's less than 70% predicted. Those patients who had extensive disease, whether it be systemic sclerosis or RA interstitial lung disease, had greater than threefold increased risk of death throughout follow-up. Interstitial lung disease doesn't just impact survival in patients. It has a broad effect on many different important patient domains. This American Thoracic Society statement on patient-centered outcomes in interstitial lung disease does a nice job of identifying the widespread burden of interstitial lung disease on patients. It includes things such as reduced health-related quality of life, reduced functional status, impacts on psychological and emotional well-being, a high symptom burden, potential need for oxygen therapy long-term. The important thing to note is that these impacts are for interstitial lung disease, but many of our patients have these domains also affected by their underlying rheumatic disease. We know rheumatic diseases affect quality of life and physical function, have a high symptom burden themselves. That is compounded when these patients develop interstitial lung disease. Finally, interstitial lung disease also has a high economic burden. In this systematic review, they estimated that the direct annual costs of interstitial lung disease and an RA and systemic sclerosis were greater than $40,000 per year. Now that we understand interstitial lung disease is frequent in people with rheumatic diseases and it dramatically affects their outcomes, we need to understand how to identify it. Now, the recent 2023 American College of Rheumatology and Chest Clinical Practice Guidelines for ILD screening and monitoring give us some guidance on risk factors for the development of interstitial lung disease. Importantly, these were not evidence-based recommendations specific to these risk factors, but rather a guide for clinicians to help us identify high-risk people. We've taken these risk factors and we've categorized them as either laboratory tests or clinical features, and we've broken them down by the specific rheumatic disease. You can see across the different rheumatic diseases that most of the lab tests that tell us about risk of interstitial lung disease relate to specific autoantibodies. For example, in systemic sclerosis, the presence of an anti-SCL70 antibody. In rheumatoid arthritis, it's having very high titer rheumatoid factor or anti-CCP antibodies. In myositis, it's having anti-synthetase or anti-MDA5 antibodies. The clinical features are indicated below. In systemic sclerosis, for example, having diffuse cutaneous disease is a risk factor. And rheumatoid arthritis, factors such as cigarette smoking or older age are associated with a higher risk of interstitial lung disease. Importantly, none of these are perfect in isolation, and thus it's imperative that the clinician understands the totality of a patient's risk of developing interstitial lung disease. These are a guide that can help us do that. Now let's go through a case of RA-associated interstitial lung disease. Our patient is a 53-year-old female who has been referred by her primary care provider for bilateral hand pain. These symptoms have been progressive over the past several months. She has been taking over-the-counter ibuprofen, which provides a little bit of relief. Unfortunately, she needs to continue taking this ibuprofen, and despite taking it, her symptoms have continued to progress. She's no longer wearing rings because she's having difficulty getting those rings on and off her hand. She works as a teacher in an elementary school and has noticed difficulty using scissors for repetitive tasks. When you examine her in clinic, you find that both her metacarpophalangeal and proximal interphalangeal joints have fullness, but do not detect any deformities at this time. You perform laboratory testing in your office, which returns with a C-reactive protein of 2.5 milligrams per deciliter, and rheumatoid factor and anti-CCP antibodies that are positive at high titers greater than 5 times the upper limit of normal. You obtain hand x-rays that were normal, and you make the diagnosis of seropositive rheumatoid arthritis. You calculate that her clinical disease activity index score is 16, putting this in the moderate disease activity range. So as we think about interstitial lung disease, what should be our next step here? Should we move forward with some additional testing, or is there more that we can do today in the office? Well, what we need to do is we need to do more in the office today. We need to do an additional history and exam focused on identifying potential risk factors of interstitial lung disease. A really important point is that when a patient with rheumatic disease sees their rheumatologist, they may not recognize that they need to tell the rheumatologist about breathing symptoms. A cough or shortness of breath they might think are not related to the rheumatic disease and that their rheumatologist is not interested in those symptoms. So we as rheumatologists need to make sure that we directly ask patients about respiratory symptoms. So in this patient, we would ask about cough. We would ask about shortness of breath. We'd assess what their exercise levels are currently, any limitations to participating in exercise, or what are the things that are most physically taxing to them right now. We'd also ask about chest pain, fatigue. When we performed our exam, we wouldn't just evaluate the joints, but we'd also listen to their heart, we'd listen to their lungs. And when we listen to the lungs, it's really important that we listen to the lung bases, which is the area of the lungs that are most typically first affected in RA-associated interstitial lung disease. As we do examine the hands, we can look for additional clues such as clubbing. And when we examine those joints and we look for the extraarticular features such as nodules, that should also be cluing us in to other extraarticular features such as interstitial lung disease. We need to assess for different risk factors. So in rheumatoid arthritis, this includes tobacco use or other inhaled or occupational exposures such as silica or coal, other extraarticular features of disease such as secondary Sjogren's, and then identifying a severe RA disease phenotype. Typically, this is things such as high disease activity, deformities. So for our patient, if we go through and do these additional assessments today, what we'd find is there are no signs or symptoms of interstitial lung disease present. There's a normal respiratory focused exam, the lungs are clear to auscultation, and none of these risk factors are present. Now, this patient returns to your clinic approximately 3 years later. She's here for follow-up of her rheumatoid arthritis. She initially had a very good response to methotrexate, then etanercept was added when persistent disease activity recurred. And while she did well for quite some time, more recently she has had a difficult course over the past year with worsening joint symptoms. This was despite switching her to adalimumab and ultimately to abatacept. When you examine her today, you notice that several metacarpal phalangeal and proximal interphalangeal joints are swollen. You detect subtle ulnar deviation and a subcutaneous nodule in her olecranon bursa. Heart is regular rate and rhythm with no murmurs, and her lungs are clear to auscultation, and you didn't detect any clubbing. When you calculate her clinical disease activity index score today, it's 36, which puts her in high disease activity, and you start talking with her about changing her disease modifying regimen. Now let's try to understand the answer to this question, and we can refer to the recent ACR CHEST guidelines for ILD screening. These guidelines provide us recommendations both for tests to do to screen for interstitial lung disease, as well as recommend against certain tests. These guidelines start by identifying patients who have rheumatic diseases and assessing the risk for interstitial lung disease. If patients are not at an increased risk, then no additional testing is recommended. For those who are at increased risk, the recommended tests are pulmonary function tests and a high-resolution CT scan. Tests that are conditionally recommended against include chest radiography, 6-minute walk test distance, ambulatory desaturation testing, and bronchoscopy. A surgical lung biopsy is strongly recommended against in these guidelines. Now let's take a closer look at the two recommended tests from this guideline. The first being high-resolution chest CT. Now, high-resolution chest CT is a non-contrast scan. And this is high resolution, meaning that we're trying to get slices that are less than 1 to 1.25 millimeters in thickness. These are inspiratory images, and occasionally we will also obtain expiratory images as well. The radiation dose of a high-resolution chest CT varies depending upon the protocol, but typically is in the range of 5 to 8 millisievert. A high-resolution chest CT is the most sensitive and specific way that we can detect interstitial lung disease. Now, pulmonary function tests, there are different components to this testing. There is spirometry, lung volumes, and diffusion capacity. And when we evaluate a patient for interstitial lung disease, we should obtain all three components. In rheumatic disease-associated interstitial lung disease, Often these PFTs can be normal early in the disease. So we may see that there are findings on chest CT that are suggestive of interstitial lung disease, but on pulmonary function testing, these can be normal. This is part of the reason that we recommend getting both of these tests to screen for interstitial lung disease. When there are abnormalities on pulmonary function testing related to interstitial lung disease, they typically are a reduced forced vital capacity, reduced total lung capacity, and reduced diffusion capacity. And in fact, a reduction in the DLCO is typically the most sensitive PFT parameter for interstitial lung disease. So let's apply these guidelines now back to our patient. So we start with a patient who has a rheumatic disease of interest like rheumatoid arthritis. The next step is we assess whether this patient is at an increased risk for interstitial lung disease. Now in this table on the right, we evaluate some of these recommended parameters from the guideline. So on her initial evaluation when we made the diagnosis, the only risk factor present was the laboratory testing. She had high titer rheumatoid factor and high titer anti-CCP antibodies. Now that we are at the 3-year follow-up, she also has a clinical criteria. She is now in high disease activity. Now, while not listed in the guideline itself, an additional risk factor we should think about in this patient is the fact that she had subcutaneous nodules. Now, we know that extraarticular RA features are a risk factor for interstitial lung disease. So from this, we really have two different options as we go back to that question. One option is that we could go ahead and do chest CT and PFTs right now. Another option is that we could continue to closely reassess the risk. And the reason that both of those are options is because we don't have clear answers for how many risk factors need to be present to make it worth pursuing these additional tests. The other question is that we don't know how confident we should be that these risk factors adequately risk stratify patients for further testing. So here is a possible approach for screening RA-ILD in this patient. At this time, we can choose to do a high-res CT and PFTs now. If we do, we'll either find that RA-ILD is present or not. If we find that RA-ILD is present, then we need to make the diagnosis of RA-ILD and start managing RA-ILD, typically in collaboration with the pulmonologist. If we do this testing now and we don't find that RA-ILD is present, then we need to reassess risk. Just because a patient may not have interstitial lung disease right now does not mean that a patient will not develop interstitial lung disease later. Another reasonable option in this patient is that in the absence of any concerning signs or symptoms, that we could plan to reassess RA-ILD risk. And when we reassess risk, if the risk has increased, we pursue high-risk CT and PFTs at that time. If the risk remains stable or even decreases over time, then we continue with our plan of reassessing RA-ILD risk. The key point is that ILD risk assessment in rheumatoid arthritis is not an activity that you can do once. This is something that you need to continue to do regularly for your patient. The other important thing is that your clinical judgment is needed. We don't have the evidence for a formulaic, algorithmic approach. We need to individualize our risk and screening approach. There are two different paths by which a patient can get to having RA interstitial lung disease. The most common path is that somebody has articular disease and later on develops interstitial lung disease. That occurs in about 80% of the time. Alternatively, patients can show up with articular disease and interstitial lung disease at the same time, or they could develop interstitial lung disease first and later develop their articular disease. But really driving home the point of why we need to reassess risk of ILD throughout the RA disease course is that the median time from RA diagnosis to RA-ILD diagnosis is about a decade. That's why this is not a one-time event. We need to reassess ILD risk. This patient returns 4 years later. They're here for follow-up of their rheumatoid arthritis, and their joint symptoms are now well controlled on tofacitinib monotherapy. Remembering this talk, you ask questions about respiratory symptoms, and now the patient tells you about a non-productive cough and some shortness of breath. When you examine them, you find there's no joint swelling, there's still that mild ulnar deviation, and still a small left olecranon bursa nodule. But now you detect some mild crackles in the bilateral lung bases, and there is still no clubbing. When you calculate the clinical disease activity index today, it is 5, which indicates low disease activity. Now, in this patient, it is clearly time to evaluate them for interstitial lung disease, and we should do that with a high-res CT and pulmonary function tests. But very importantly, this is a different situation than we previously talked about. When we talked about the guideline before, we talked about screening for the presence of interstitial lung disease. But that's not the situation we are in. The patient is now telling us about symptoms that are very concerning for interstitial lung disease, and our exam has revealed additional findings such as crackles in the lung bases. So at this time, we are no longer screening for ILD, but we are making the diagnosis of interstitial lung disease. We talked about during the screening that there's different ways we could do this. Different times, some people may get the CT and PFTs versus waiting and reassessing risk. But when there are symptoms and signs present of interstitial lung disease, it is always warranted to evaluate further. And when we're evaluating interstitial lung disease, that should be with the high-res CT and pulmonary function tests. Now, we do need to keep a broad differential and remember that sometimes the symptoms of interstitial lung disease may also be symptoms that can occur with other conditions, such as cardiovascular disease. We also want to make sure that we're engaging our pulmonologist early in the disease process. They have expertise that can be very helpful for evaluating and managing patients with interstitial lung disease. And now I'd like to turn it over to my colleague, Dr. Castellino, to take us through another case.
Thank you, Dr. England. So let's move on to a case of scleroderma ILD. This is a 73-year-old female with hyperlipidemia, seasonal allergies, osteoarthritis, status post bilateral hip replacements, who presented with a recent onset of hand swelling over the last 2 months. She was seen by rheumatology closer to home and found to have a positive CCP antibody and started on methotrexate for rheumatoid arthritis. But to date, she didn't have any effect with the medication. She's also found that her fingers feel puffy and she has blanching of her digits when she goes to the grocery store. She's also having some shortness of breath with walking, having a hard time keeping up with her husband. And in the last 3 months, going up a flight of stairs is more difficult. Let's review her physical exam. She has a normal blood pressure of 123/80 with a pulse of 65. She's afebrile and satting 98% on room air. Pertinent positives on the physical exam include evidence of thin lips. She also has evidence of Moscow facies or furrowing of the upper part of the mouth. And then other pertinent positives on exam include evidence of sclerodactyly. Shown here on the right is a photograph of her hands, showing some evidence of Raynaud's as well as some tightening to the fingers. On closer look, she also has evidence of periungual erythema. There's no evidence of synovitis and no joint swelling in the lower extremities. In terms of her skin exam, she has areas of hypopigmentation along the scalp. There's no evidence of ulcers. On nail fold capillary exam, there's some evidence of capillary dropout as well as linear capillaries. And when we assess her skin score, she has a modified Rodnan skin score of 5 out of a total of 51. In terms of lab workup, she has a normal CBC, a normal chemistry, and liver function tests. Her rheumatoid factor is 11, and her repeat CCP antibody is less than 8. Her inflammatory markers show an ESR of 33 and a CRP of 0.6. In terms of her serologic workup, she has an ANA that's positive at 1 to 640, a positive SCL70 antibody, and the remainder of her extractable nuclear antigens are negative. So let's review her pulmonary function testing and echocardiogram. Shown here in this table is her pulmonary function testing. Her FEV1 is 79% predicted. FVC is 75% predicted with an FEV1 FVC ratio of 104%. And her DLCO is at 52% predicted. So these pulmonary function tests show that she has normal spirometry and a reduced single breath diffusion capacity. In terms of her echocardiogram, she has an ejection fraction of 65% with an estimated right ventricular systolic pressure of 30. Here is her high-resolution CT of their chest. In the red arrows, what you're looking at is evidence of ground glass opacities, and these are predominantly in the lower lobes. In terms of the blue arrows, she has evidence of traction bronchiectasis. So putting this together, this suggests more of an NSIP pattern, as you heard from Dr. England. So our patient was started on mycophenolate with a gradual up titration to 1,500 milligrams twice daily over weeks, and this was started for both her skin and her lung. And as we've monitored her breathing tests, shown here on the left with the baseline PFTs, and then again at 6 months and 12 months, you can see that the spirometry continues to remain normal, and there is a mild increase in her diffusion capacity, going up to 59% at 12 months. In this next section, we'll cover the new treatment guidelines and emerging therapies for SARD ILD. So the ACR chest guidelines were recently published for the treatment of SARD ILD. The first-line treatment for each of the rheumatic conditions is outlined in this chart, and the treatments are listed in order based on hierarchy of voting. For SARD ILD, the guidelines conditionally recommend mycophenolate, azathioprine, rituximab, and cyclophosphamide as a first-line treatment option, with mycophenolate being conditionally recommended over the other treatments across the different diseases. For SARD ILD, other than systemic sclerosis ILD, there's a conditional recommendation for glucocorticoids as first-line ILD treatment. It's important to note that glucocorticoids are strongly recommended against for patients with SSC ILD. This slide reviews the ACR chest ILD guidelines for progression despite first-line ILD treatment. For patients with SARD ILD progression, despite first ILD treatment, it's conditionally recommended that patients be started on either mycophenolate, rituximab, cyclophosphamide, and nintedanib. In patients with rheumatoid arthritis ILD, pirfenidone may also be considered. And once again, there's a strong recommendation against corticosteroids for systemic sclerosis ILD. Let's review the ACR chest guidelines for rapidly progressive ILD. For patients with rapidly progressive ILD, pulse intravenous methylprednisolone is indicated as a first-line treatment for rapidly progressive ILD. For patients with SARD and rapidly progressive ILD, it's conditionally recommended that rituximab, cyclophosphamide, IVIG, mycophenolate, a calcineurin inhibitor, and a JAK inhibitor are considered as first-line treatment options. Now, rituximab and cyclophosphamide are recommended over IVIG, but IVIG may be a preferred option, especially if there's high concern for infection. I also want to briefly mention the ATS, American Thoracic Society, treatment recommendations for systemic sclerosis ILD. There's a strong rationale for mycophenolate, as I've already mentioned, for systemic sclerosis ILD. And the ATS treatment recommendations conditionally favor cyclophosphamide, rituximab, tocilizumab, nintedanib, or nintedanib plus mycophenolate as next-line treatments. Additionally, some research recommendations include pirfenidone and then pirfenidone in the combination of mycophenolate. In the next few slides, we'll review the recent clinical trials in SARD ILD. We'll first review some of the trials in systemic sclerosis ILD, then talk a little bit about myositis ILD, and finally close with RA ILD. The SLS2 study was a double-blind randomized controlled trial of mycophenolate for 2 years compared to oral cyclophosphamide for 1 year. And the primary endpoint in the SLS2 study was a change in FVC percent predicted over 24 months. What the study found is that there were comparable improvements in FVC in both the treatment groups at 24 months, as shown in this graph. Additionally, the skin score improved in both treatment arms, with a trend favoring the cyclophosphamide arm. In the mycophenolate group, there was less leukopenia and thrombocytopenia. And what this study concluded is that both mycophenolate and cyclophosphamide are efficacious for the treatment of SSc-ILD. However, mycophenolate has become the first-line treatment given the side effect profile. The census study evaluated nintedanib in SSc-ILD. And this study compared 150 milligrams of nintedanib twice daily compared to placebo for 52 weeks. The primary endpoint in the study was the annual rate of decline in forced vital capacity. What the study found was that the annual rate of change in FVC was at minus 52.4 milliliters per year in the nintedanib group compared to negative 93.3 milliliters per year in the placebo group. There was no effect of nintedanib on the skin score or on patient-reported outcomes. And one of the more common side effects was diarrhea. So nintedanib certainly has now been approved for treatment of systemic sclerosis ILD. Briefly want to mention tocilizumab, as this is now FDA approved for the treatment of SSc-ILD. The FOCUS study was a phase 3 trial looking at the efficacy of tocilizumab in systemic sclerosis for 48 weeks. The primary endpoint here was a change in modified Rodnan skin score, with a secondary endpoint of a change in forced vital capacity. 210 patients were randomized to either receive tocilizumab 162 milligrams weekly compared to placebo. It's important to note that in this study, not all patients had ILD, and patients were also required to have an elevated CRP level. The FDA approved tocilizumab to slow the rate of decline in FVC in ILD. And one thing to note is tocilizumab is not approved for skin. So when do we use tocilizumab in systemic sclerosis ILD? It may be used in patients with early systemic sclerosis and interstitial lung disease, certainly those patients that have early evidence of ILD progression, and those who may be unable to take mycophenolate. Some common adverse effects with tocilizumab include risk of upper respiratory infections, headache, elevated liver function testing, and injection site reactions. I'd like to review the RECITAL study, which looked at rituximab compared to IV cyclophosphamide in SARD ILD. So this was a phase 2b randomized controlled trial looking at patients with severe progressive ILD related to systemic sclerosis, idiopathic inflammatory myositis, or mixed connective tissue disease, and this took place in the United Kingdom. The study compared rituximab given at weeks 0 and 2 weeks IV compared to cyclophosphamide, and there were 101 participants enrolled in the study. The primary endpoint here was a rate of change of FVC at 24 weeks. What the study found is that the FVC improved from baseline in both the cyclophosphamide and rituximab groups. There were fewer adverse events with rituximab compared to cyclophosphamide. And the rituximab group, there was improved skin score in those patients with systemic sclerosis. So what this study concluded is that rituximab is not superior to cyclophosphamide. However, it can be considered as a treatment option in refractory SARD ILD, including systemic sclerosis ILD. Now, there was a lot of excitement about SLS3 coming out comparing pirfenidone and mycophenolate. This trial took place during the pandemic, and it was a multi-center double-blind phase 2 randomized controlled trial. The inclusion criteria here included active and symptomatic SSc-ILD. The treatment arms included mycophenolate and placebo compared to mycophenolate and pirfenidone. And the primary outcome was a forced vital capacity assessed every 3 months over 18 months. The challenges of doing this trial during the pandemic is that it was unable to assess the primary outcome. So one of the challenges was identifying patients who were naive for mycophenolate, and the other was the pandemic itself, resulting in premature closure of enrollment. Briefly want to review lung transplant in systemic sclerosis ILD, as it has shown to improve survival in patients with SSc-ILD. Considerations for transplant include a failure to respond to prior treatments, and as long as a patient does not have any extrapulmonary contraindications, such as active systemic disease, an increased risk of aspiration from esophageal dysmotility and gastroparesis, and any evidence of severe vasculopathy, such as severe Raynaud's phenomenon with digital ulcers. Let's move on to the treatments for myositis ILD. So this chart summarizes the various treatment options for myositis ILD. And the first-line treatment initially is starting with corticosteroids with the addition of a steroid-sparing agent. There's a lot of variability in terms of practice. As I mentioned previously with the ACR chest guidelines, mycophenolate Mofetil has come to the foreground in terms of treatment for myositis ILD. However, other steroid-sparing agents are used as well, including azathioprine, tacrolimus, IVIG is primarily used for myositis, but can be indicated in certain cases of myositis ILD. And then rituximab is primarily indicated as an adjunctive treatment or for rapidly progressive ILD. Cyclophosphamide, while one of the treatment options, is further down the list in terms of treatment for myositis ILD. I briefly want to review the abatacept study in myositis ILD. So this was a pilot trial looking at patients with antisynthetase syndrome associated interstitial lung disease. And there were a total of 20 patients enrolled, 9 in the abatacept group and 11 in the placebo group. And patients were treated for 24 weeks and then participated in an open label extension. The primary endpoint here was a change in FVC percent predicted from baseline compared to week 24. What the study found is that abatacept did not significantly improve percent FVC at 24 weeks. There were trends at 48 weeks to suggest a potential benefit. However, further larger studies are warranted to really look at abatacept in myositis ILD. Let's review the treatments for RA-ILD. So the traditional agents include initiating therapy with steroids, and then, as I've mentioned, the other immunosuppressive agents, including mycophenolate, cyclophosphamide, and azathioprine. Now, I want to highlight the different biologic treatments that are used and are approved for treatment of rheumatoid arthritis, but may also have benefit in RA-ILD. But there's still studies to be done on this. And these treatments include abatacept, rituximab, and tocilizumab. In terms of other agents, nintedanib has now been approved for progressive pulmonary fibrosis and could be indicated in a patient with RA-ILD who's progressing, as well as pirfenidone. Now, in terms of immunosuppression in rheumatoid arthritis ILD, there's no randomized control trial data available to support immunosuppression in RA-ILD. This study was a retrospective analysis looking at RA-ILD patients that were treated with mycophenolate, azathioprine, or rituximab at 5 different ILD centers. And they looked at change in lung function, looking at FVC percent predicted and DLCO percent predicted before and after treatment. They looked at 212 patients with RA-ILD. 92 patients were treated with azathioprine, 77 patients were treated with mycophenolate, and 43 patients were treated with rituximab. What they found is that immunosuppression is associated with an improved FVC and DLCO trajectory compared to those pre-treatment lung function. The TRAIL-1 study looked at pirfenidone and RA-ILD. So this was a phase 2 double-blind randomized controlled trial that compared pirfenidone daily compared to placebo. The primary endpoint here was a decline from baseline in FVC percent predicted of 10% or more, or death during the 52-week treatment period. 123 patients were randomly assigned, 63 to the pirfenidone group and 60 to the placebo group. Unfortunately, this trial had to be stopped early due to slow recruitment with the pandemic, and it did not meet its primary endpoint. There were, however, trends that show that pirfenidone slowed the rate of decline of FVC over time in patients with RALD, and certainly further studies are indicated. I'd like to mention the INBUILT study, as this looked at progressive pulmonary fibrosis. And this was a phase 3 randomized controls trial looking at nintedanib compared to placebo in patients with fibrosing lung disease that was affecting more than 10% of lung volume on a high-res CT of the chest. In this trial, there were 82 patients with autoimmune ILD or SARD ILD. And of these, 42 had rheumatoid arthritis ILD, 23 with SSC ILD, and 7 with mixed connective tissue disease ILD, and 10 with other autoimmune ILD. The primary endpoint here was an annual rate of decline in FVC over 52 weeks. And what the study found, looking at the adjusted rate of decline in FVC, the nintedanib group did better compared to the placebo group, as shown here. And as I mentioned previously in the census study, diarrhea here was also a common side effect. So nintedanib is now FDA approved for progressive pulmonary fibrosis. So it's an exciting time in the development of treatment for SARD ILD. This table here outlines the new drugs that are being studied. Nerandomilast, a phosphodiesterase 4 inhibitor, recently met its primary endpoint of an absolute change from baseline in FVC in a phase 3 study of idiopathic pulmonary fibrosis and a phase 3 study of progressive pulmonary fibrosis. And a SARD ILD study will be starting this fall. Some of the other medications that are being evaluated in SARD ILD include continuation of studies with pirfenidone, belimumab, which is an anti-B lymphocyte stimulator, monoclonal antibody, amlitelimab, which is an anti-OX40 ligand antibody, and then the other agents are listed here. So let's review the key conclusions and takeaways from this talk. ILD is a common and devastating complication of systemic autoimmune rheumatic diseases that requires vigilance of the clinician and repeated risk assessment to detect at an early stage. High-risk CT of the chest and complete PFTs are the tests of choice for evaluating suspected SARD ILD as part of screening or diagnostic evaluations. In terms of the preferred treatment, mycophenolate mofetil is the preferred treatment for SARD ILD. And nintedanib is now FDA approved for the treatment of progressive pulmonary fibrosis as well as SSc-ILD. We'd like to thank you for your participation in this program. Please go to the next slide to complete the evaluation for the program and to apply for CME credit. Thank you very much.